Hi, everybody. Welcome back to this image critique series that we've been working on. Um, this week, we're going to talk about a knee series. Uh, I hope everybody's had a good October so far and enjoying the cooler weather. I know it's been a good October for me. Um, let's get started. Like I said before, we're going to go over a knee series, kind of look and see what we need to be seeing when we shoot a knee. Okay. And we're going to use the PACEMAN acronym again. We'll kind of go through these images and make sure they do have what we need to see. And if they don't, we'll talk about that. Okay. So let's start with an AP knee uh, projection. So here we have an AP knee. It's actually a really good AP knee. Position wise, it's really, really nice. You can see that we have the patella right here in the middle of the distal femur right there. Now the apex of the patella, it kind of comes down at a point right here. Uh, on a perfect knee X-ray, that should be pointing right down the intercondylar notch right there, down into the tibia, which is pretty dang close to in the middle, but you can see the outline of it. You can see that the apex is pointing right down in between the condyles right there. Um, Area, yeah, we've included the area that we need to include. A good rule of thumb on an X-ray is we include a third of the femur and a third of the tib fib, along, of course, with the actual knee joint itself. So yeah, good X-ray. Collimation, we're collimated pretty nice. You can see the collimation lines right here. Okay, oh, I'm sorry about that, guys. Um, yeah, collimated, very, very nice. Nice and tight to the skin margins, both laterally and medially. We haven't cut any skin margins off. We're able to see good muscular tissue. Uh, but yeah, good collimation. Exposure wise, very, very nice. Like I say, we can see good muscular tone, and the differentiation between muscle groups. We can see a good outline of the skin margin. And when we get into the bone, we've got good sharp differentiation between soft tissue and bone. We can see the periosteum very, very well. It's nice and preserved. Not a lot of arthritis going on here. Um, we're able to see the intercondylar eminence. It's these two horn-like things that come up in the middle of the superior tibia right there. That's where your anterior cruciate ligament runs through. Uh, yeah, we can see got good joint line there. We can see through that joint really well. You'll note that the fibula is slightly superimposed superiorly with the lateral um, tibia right there. About a third of the tibia is superimposed, which is what you want to see. Once you start seeing your tibia superimposed with your fibula on your AP knee, you know that you're rotated way too much. The key is to try and get that patella in the middle of the femur, right? So it points down through the intercondylar space right there, and then have a slight superimposition with your superior tibia and fibula. So, yeah, very, very good contrast. We're able to see good bony trabeculi. Yeah, nice image. Marker, yep, we've got a right marker right there. It's on the lateral side, so we know that this is a right knee. Aesthetically speaking, this is a nice X-ray of an AP knee. Um, it's very nice. It's marked well. It's shot well. It's positioned well. Very good job. So let's move on to the lateral projection. Lateral projections can be kind of tricky when it comes to the knee. There's a couple things that you need to pay attention to. Position wise, this one is positioned really nice. The knee is bent probably around 37 degrees. Proper, 30 to 40 degrees of a knee bend is acceptable. You don't want to have it bent too much or too little. Um, but yeah, collimation, or sorry, the area, we've included the entire area that we need to include. We've got a third of the femur, a third of the tib fib, and the joint itself. Collimation wise, it's a good job collimating. We could be down a little bit on the top side, but uh, definitely okay. We've got skin margins anteriorly and skin margins posteriorly. So very, very nice collimation. The exposure itself is nice. It looks like we use the same technique we used for the AP for the lateral. Uh, yeah, very, very nice. We're able to see good soft tissue, good bone, good periosteum. Intermedullary spaces are well defined. We can actually see a little joint space between the patella and the femur right there. You'll note that up and down, our rotation is perfect. There's very, very little sliver of the lateral condyle behind the medial condyle right here, but very acceptable. Um, it looks like we have a little bit more up front. It's all in the way you position your knee. You need to make sure that knee is lateral against the image receptor, even if you have to lift the anterior knee a little bit. If we'd have just lifted the knee a little bit right here, we would be superimposed right here as well. But all in all, good. That's good lateral. You want to try and get your medial and condyle, medial and lateral condyles superimposed over each other, so it looks like one condyle. Here we have a little bit of overlap with the medial or the lateral condyle, so we know that we're a little bit under rotated. So we could rotate a little bit more and be okay. Uh, Marker, yep. Again, we've got the right marker right there. It's on the anterior side on the lateral, which is what we like. The contrast is nice. We can see the whole popliteal area back here. You see a little vascular image right there that we can see really well. It's a nice picture. Good job. So for a knee series here at Sterling, we're going to shoot an AP lateral, and upon request, we'll shoot a patella or a skyline view. There's various names for it. We're just shooting the patella, but that's what we'll look at next. So here we have two different pictures. I just wanted to show one with a fracture, so you can see the reasoning behind why we do these. If a patient has anterior knee pain of any sort, we're going to shoot a patella shot. Okay. Now on the Paxis 100 machine, it's a little bit tricky. There's a couple different ways we can do that. I'm pretty sure I've sent a video out on that. You can do them upright, and you can also do them laying on the table. For me, I prefer to do my patellas bilateral. I just think it's a little bit easier, and it gives the provider a little more information and comparison value with both patellas. But so position wise, we're positioned really well on both of these. Actually, we're able to see the joint space between the inferior patella and the intercondylar groove right there. That patella should ride right through the middle of that, and they do on both of these. So area, we've included the area we need to include. The area we do need to include is, of course, the top of the knee. We also want to include that joint space right there and slightly below. Okay, so collimation, we're actually opened a little bit more than we need to be, but definitely would not redo this for any reason. So exposure wise, it's great. We've got good contrast. We're able to see soft tissue on both. Maybe we're a little bit overexposed on this one, but not terribly. We're able to see the joint lines very, very well on both of these. Okay, we got good space to see through there. We can see the top of the femur very well. Periosteum is well preserved, other than right here on the patella where that fracture is. Pretty impressive little fracture right there. Looks like it may hurt a little bit. We've got a left marker over here, so we know that that's a left. However, there is no marker seen on this one. We need to make sure that we're marking the lateral side of the patella with either a left or a right. Um, so this one looks like it's probably a right, so we need a right marker right there. Okay, and this one is obviously a left. So aesthetics, it's a nice patella shot. Uh, Sunrise view, skyline view, whatever you want to call it. Um, this is what you want to look for. This is what you want to see. You know, if you start having superimposition with your inferior patella, with your femur, uh, you know that you need to do a little better. And you know, patellas take a little bit of time to get used to. You just need to be able to visualize the top of the knee and where that patella lies, and the space that it generates between itself and the femur, and that's what you're shooting for. So look up the knee imaging tutorial that I did. I know I talk about uh, you know the patella shot. Um, if you think that you need a little more information on that, please let me know, and I can put together a tutorial showing you just how to do the sunrise views. So anyway, but aesthetically speaking, it's a nice X-ray. So this is our series. We got the AP projection, we've got the lateral projection, and we've got the sunrise view. Okay. Um, let's go down here. There are a couple different views that, you know, if you ever work in an orthopedic clinic, or sometimes our docs will want a standing knee X-ray, and at that point we're going to do a bilateral AP. We'll do a lateral of the affected knee, and then we'll try and do a bilateral sunrise. Uh, some doctors, if they're looking for acute arthritis or patient is bone on bone, needs a total knee, we'll do a tunnel view, which is a PA view with the patient bending their knees into the image receptor. It's actually a pretty neat picture. You'll note that here we've got an AP. Okay, you've got a good joint line right there, and here we've got a PA tunnel view. Okay. And the reason they call it a tunnel view is you can see through the intercondylar notch really, really well. It also shows the joint line a little bit better uh, to see if there is contact between the tibia and the femur, or lack of joint space, kind of like right here. You can see that that's bone on bone right there. Probably a candidate for a knee replacement. And here we've got the tunnel view where you can see through the tunnel, but we can also see that there's bone on bone right here on the medial side. It's a good detector of arthritis. And I will do a tutorial at some point on how to do a tunnel view. They're kind of a neat picture to look at as far as knee. Uh, interesting to see the difference between the AP and the PA. We can actually see through that tunnel a little bit better on the PA. And we don't do that as protocol, but can do upon request. If you ever are requested to do a tunnel view and you're unsure how to do that, or can't find it in your positioning book, please give me a call and I can walk you through that. And I'll work on putting together a tutorial for that. Okay, anyway, I hope today was helpful. Um, this is what you need to be seeing on knees, guys. Don't over collimate. Collimate as tightly as you can. Make sure you include a third and a third. Make sure you get a good picture of the joint line, the knee joint line. Make sure that when you position that patient is parallel with the image receptor, so that you do get a good AP picture. If you're rotated one way or the other, if your fibula is sticking clear out here, you know you're rotated too far medially. If you're superimposed with the tibia right here, you know that you're under rotated. That you're rotated to the lateral side, so you need to straighten it up a little bit. I found it helpful to put my hand behind the patient's knee, right in the popliteal fossa, and you can tell if your hand is parallel with the image receptor. Just have them turn their toe in or out, whichever way they need to rotate, and you can usually get a perfect AP projection every time doing that. And I think I covered that a little bit in my tutorial. If not, I'll review that and make that change if I need to. Um, on your laterals, just make sure that your knee is uh, again parallel with the image receptor. Um, and you can see how that knee comes down. If the patient has bigger hips, it's going to come down at an angle, right? So you're going to need to rotate your angle your tube about 5 to 7 degrees in order to get that joint line right. Knees or lateral knees take a while to get good at, and it just takes practice and patience. So I do look at a lot of x-rays that you guys take, and there's a lot of good knees out there. So good job. Keep up the good work. I hope this is helpful, and we'll see you next week. I think we're going to talk about the femur or calcaneus or something like that. Anyway, thank you so much. Have a great day. Enjoy this fall that we're having, and we'll talk to you soon.